It is now my honor to introduce to you Russ Kaino, MD. Dr. Kaino is the Medical Director of Emergency Services at Providence St. John Health Center. He is also the Chief Medical Information Officer there. And most of us can attest to how busy an emergency room is, and St. John's confirmed that because 60% of all hospital admissions flow through that emergency department. So a very busy day that he has every single day, and that department serves approximately 30,000 patients per year. Dr. Kaino's real passion lies in improving hospital efficiency, which he believes is the underpinning of safety, quality, and customer satisfaction. He's been with St. John's for 28 years, and he is a physician's trustee there. He's had experience in working in emergency departments all over Los Angeles, including Santa Monica and Big Bear. He also volunteered for 3 years as a flight physician on a medical helicopter service that covered Southern California. So we all now know that not only is he calm under pressure, but he is not afraid of heights. So Dr. Kaino was born and raised in Western Australia, so you'll hear that wonderful accent with us today. He completed medical school there and worked in emergency medicine for 5 years before coming here to the United States. He also served in the Royal Flying Doctor Service in the outback of Australia. And I'm sure we'll hear a couple of those stories of some of the perils that they've had to endure. But he was also a volunteer doctor in East and Central Africa, as well as the Amazon. And he did tell me that after all of that, even being in the emergency room in Santa Monica is still as wild and crazy as being in the Amazon. So he is board certified in emergency medicine in both the US and Australia. And in Australia, he won an award for graduating with the highest honors in the country in the specialty of emergency medicine. Outside of work, he is passionate about his wife and his 3 children. And he is an avid surfer, waking up early in the morning to get his surf sessions in. He's been surfing since he was 7 years old, and he's taken that calmness that he experienced as a child in the waves and the water and brought that to the emergency room. So ladies, if you ever had a question for an ER doctor, today is your chance. Please help me welcome Dr. Russ Kaino. Welcome,
Thank you so much, Vanessa. Wow, firstly, that blessing that you gave was so beautiful. Thank you. And that was one heck of an intro, that's for sure. So thanks so much for that. It's really a pleasure to be here and talk with you all. As I was saying to Vanessa earlier, I've had a bit of background with Pepperdine. I used to work with the student health there some years back, and we had a program giving remote telehealth to students at Pepperdine about 15 years ago. We were way ahead of our time. So what can I tell you, Vanessa?
Absolutely. Well, we heard a little bit about your background, but if you would share with us what brought you to emergency medicine as opposed to all the other facets of medicine, and maybe share with us some of that unique training that goes into being an ER doctor or overseeing an ER.
Sure. So when I was in medical school, we rotate through every specialty, and I enjoyed every single specialty, and I wanted to specialize in each one as I went. When I graduated, I actually decided I would go into obstetrics and gynecology because it's the one happy reason that people go to a hospital for. It's the only happy reason people go to a hospital. And I started doing that for a year and then realized it was too narrow for me. And then I flipped completely and went into anesthesiology and was in the OR for a year doing anesthetics. And I realized it was too boring. So then I quit and traveled around the year by myself with the backpack, traveled around the world, and which is why I ended up here actually during those travels. And during that time, I decided I wanted to do emergency medicine because I went back to that frame of mind where I enjoyed everything. And that is the one specialty where you can do everything And it's actually the best part of every specialty. It's not the boring, repetitive maintenance part. It's the icing on the cake part of every specialty, whether it's dermatology, psychiatry, cardiology. We do, we're a jack of all trades. You could say a master of none. But we manage the emergency part of every specialty. And so we have to know that slice of every specialty, and it's fun. And you work with a great team of people. It's very, you're working with a large team. So you have a lot of company all the time, nurses, other doctors, techs, clerical people. And you interface with every other specialty. So, we do the assessment. It's our job to figure out what the problem is, stabilize the patient, and then hand them over to a doctor who will do the definitive care, take them to the OR or the cath lab, manage the stroke or the heart attack or the appendicitis. So we get to be the sleuth and figure out what the problem is. So it's a very cognitive specialty where you're doing a lot of thinking, listening to the patient, and piecing together suspicious pieces of information. And we also do a lot of procedures. We do a lot of life-saving procedures, which gives you immense instant gratification. You save people, you have people who have a cardiac arrest in front of you and die, and you shock them and they wake up right away and say what happened, and you just smile and you keep going, but you know that, you saved a life today. So you get to do a lot of great things. We have to do a lot of really difficult things too. We have to deal with people who don't make it. We have to call families and tell them that their loved one didn't make it, or tell them in the waiting room, which is by far the most horrible part of the job. But it's a job that picks you up and wrings you out. It's a whole life, whole body experience in the deepest, most thorough sense of the word. Because you work a shift there, and you walk into work, and before you know it, you're walking out, and the day passes so quickly. You don't have time to eat often. Going to the bathroom can be a real challenge when you're juggling 8 or 9 really sick patients and running from room to room, and you don't have any control over what happens. The patients come in as they come in, and so some days it can be really challenging, and you're just going from patient to patient and juggling difficult scenarios. So we get trained in all of this, and we rotate through all these different specialties during our residency, which I did mine at UCLA and in Australia. And it's a lot of fun. We get to know lots and lots of doctors. We're really the ideal person to call if you want to know who's the right doctor to go to for X or Y or Z, because we see all of how they practice. We see if they come in. We see how they talk to the patients. We see how careful they are. We see what questions they ask us and how diligent they are when they take our sign outs. When I'm handing over a patient to a cardiologist or a surgeon, I see, how thoughtful they are. So, we really have a bird's eye view of all of medicine where we are. And, but we have a tough job. And, I sort of feel like most emergency physicians are like the fighter pilots of emergency medicine. We're really out there. It's all encompassing. It's really intense. And when you start a shift, it's, you're all in. There's no distraction, no calls to home. There's no, calling some follow-up errand you had to do. You can't do anything like that when you're on a shift. You're just all in. So does that answer your question?
Fantastic, yes. So ladies, if you're taking notes, the first one or one that should be on there is best referral service would be an ER doctor. So that is good to know. So we've heard a bit from your background that you've worked in Central Australia, the Outback, Africa, the Amazon. Of all of these, how did you come to California, and then how did you settle on St. John's since you've been there almost 30 years?
Yeah, well, some of that was during a year I took off just to travel, and some of it was during my time at UCLA and beyond. As I mentioned before, I graduated from emergency medicine in my fellowship at UCLA. And then I worked as full-time faculty at UCLA, teaching emergency medicine to residents. And it was during those years that I did a lot of that travel and fun stuff. And then I was working at UCLA and really had the life of an academic doctor. And the 94 earthquake occurred and shut the St. John's down. And they reopened the hospital and offered the bid for running the emergency department. And myself and 3 other residents, we were all residents together at UCLA. We decided we would throw our hat in the ring and see what happened. And I think there were about 70 applications, 70 groups applied to do that. And unbelievably, at the end of the day, we were the group left standing. So it's been a great 28 years. And the 4 of us are still there, still doing our same thing. We, as I said, we're residents together. So we work together at UCLA. And we're like 4 brothers, and it's been a 28-year marriage between us, and it's been amazing. And we're very close and look after each other and love what we do. And the real reason I think we all moved to St. John's is because we had pretty good careers at UCLA, and it's a good hospital for exotic problems. But you can tell the level of satisfaction and the caliber of practice is higher at St. John's, and we wanted to go up. And the patients are happier because there's less bureaucracy, there's no teaching, so there's no residents. It's much more private. Everybody's board certified, and things happen more quickly. There's no chain of command with the intern to the resident, to the senior resident, to the fellow, to the attending. It's just the attending and the nurses. And so it's a completely different environment for the patients. They get a lot more instant gratification with their care. The caliber of care is higher. The only caveat to that is, if you need a lung transplant or a heart transplant or a liver transplant, sure, I'd go to UCLA. But for a gallbladder, a heart attack, a broken leg, a broken hip, COVID, I'd go to St. John's because I know for a fact we can take better care of patients there. And so it was really a matter of professional satisfaction and enjoying the job, because when your patients are happy and less frustrated, it makes the job so much nicer. And so, emergency medicine is a difficult specialty. A lot of, it's got a 60 to 70% burnout rate. It's a tough job. So if you can enjoy the journey and enjoy the patients and have enough space to make friends with the patients and chat with them, and have that personal connection, that's really the secret of not burning out and enjoying the journey and not worrying about the destination, but enjoying every day and connecting with people. And that's what makes it fun. So that's really, and also the other thing is, St. John's is a community hospital, but we are able to deliver university level care in a community hospital setting. And that is so rare and unique. With our St. John's Cancer Institute and Hip and Pelvis and Pacific Neuroscience Institute, I mean, it's really quite remarkable. So from a doctor's point of view, it's very satisfying. And, this is the place where I want to get my care, where all my family gets their care, because it's all the doctors there are doctors. So, we know what's good and what's not, and we get our own care there. So, and in fact, we look after a lot of faculty and medical staff from Cedars and UCLA actually who come to us. It's more private, and I think they value the care. So that's my reason for being at St. John's.
Thank you. Well, you mentioned broken bones, heart attack. I know ladies on this Zoom today, excuse me, we are mothers, we are caretakers. A lot of that medical responsibility falls to us. So maybe can you explain the difference between a medical emergency that maybe you would approach a hospital ER versus a lot of these outpatient or urgent care centers are in our neighborhood. So could you give us maybe kind of a delineation between when to use which one?
Yeah, I think anytime you suspect you would need a specialist, an urgent x-ray, an exotic lab test, a CAT scan, an ultrasound, or you think you might need to be admitted and cared for because you're just not going to be able to manage at home, then I would go to an emergency department. If you've obviously got something where you think, I want to know what it is, I've got a twisted ankle or a laceration, or I've got a cold, those kinds, and where you don't think you're going to end up needing anything major or exotic or being cared for, I think an urgent care is great. And I would encourage that. But I think those are the things, if really, if you're going to need a specialist of any kind immediately, if you're going to need a CAT scan or a sort of complicated x-ray or to be admitted, then you should go to a hospital emergency department.
Thank you. And we couldn't have a medical discussion without talking about COVID-19. So we have seen a lot in our last 2 years. Yeah. A lot of us have been fed information about hospitals being overrun or mask mandates being based upon how many open beds there are in a medical center. So could you basically share with us your experience with COVID-19 running an ER? Talk to us about the number of beds, the weight that was put on to the hospital in general, and maybe some of your outlook as we look towards a lot of mandates being lifted, but also variants in our future.
Yeah. Well, it's been a really wild ride. It really has. But we were trained for this, and all during my residency. In fact, I remember when I was a medical student, the professor of microbiology said, well, we've eliminated smallpox, but something will take its place, because that's the natural order of things. It's just a matter of time, and it will happen. And then we had HIV. And we've got HIV in some respects under control, in some respects, in some countries. But the fact that this pandemic came up in the way that it came up is not at all surprising. And to be honest with you, I had thought this would happen every time we had those scares over SARS and MERS earlier, over the last 20 years. I thought this was likely to happen. Bird flu and all those sort of things. So this is not a bit surprising, and this is something, a pandemic is something that we, were prepared for in residency. So I think that the medicine itself has been fairly straightforward. It's really more the logistics that have been really challenging. And to some degree, the fear factor of working in and amongst it for ourselves, that was really hard at the beginning, where we had, our youngest, healthiest doctors on death's doorstep in the ICU. That was really heavy. In fact, we had our youngest doctor, a really big, strapping, healthy guy from Wisconsin. His wife works at UCLA, and he works in our emergency department. he got really sick. He went to the ER at UCLA because his wife, they live around the corner and his wife worked there. And he got hospitalized at UCLA and he was getting sicker and sicker and sicker. And I said, well, aren't they giving you one of the monoclonal antibodies? And he said, you know, I don't qualify. And I said, but we have a trial here at St. John's and we have it and we can give it to you. And so he asked, and his wife asked the folks there to give it to him and they wouldn't. So we said basically, well, tell them that if they don't give it to you, we'll transfer you to St. John's and we'll give it to you here. And he was about to be intubated in the ICU. He was really frightened because he knew all the ins and outs of it all. And with the threat of us taking him to St. John's from UCLA, they gave it to him. And 18 hours later, he was discharged home after that monoclonal antibody therapy. It was staggering, the degree of turnaround. So we've had some amazing stories that we've seen with our own patients. Our biggest challenge is, you know, our volume dropped initially. You know, the patients just vanished into thin air. Even appendicitis stopped happening. It was just incredibly weird. Strokes and heart attacks stopped. It's really hard to explain how that possibly could have happened. And we lost about 60% of our volume. And but the volume we did get was COVID. And one of the unique things that St. John's had is that we have this program which uses ECMO, extracorporeal membrane oxygenation, which is a way to oxygenate the lungs through a machine. And there's only 9 of these devices in California, and 7 of them are at St. John's. So we were getting people from all over California, from UCLA, from Cedars, from everywhere, were sending their patients to us. So our ICU was overloaded with really sick people who were on death's door. And we had roughly a 50% survival rate of all those people, who for sure all of them would have died had they not been able to get this ECMO. And so we got a lot of people coming in because of this expertise we offered. And we had a lot of very progressive trials that other hospitals didn't have because of our cancer center switched all of its attention from treating cancer and used all of their genetic expertise and precision medicine with genomic treatments, et cetera. And they swung the gun from treating cancer to treating COVID. And we had these incredible trials that other hospitals weren't able to secure. And we were giving drugs that nobody else had. And we were able to have a profound effect with that. So, you know, obviously we had all kinds of logistic issues, putting up tents, figuring out how to ventilate the emergency department a lot more effectively, getting PPE, and our foundation supplied us with a huge amount of PPE, and that was a saving grace for many of us. So there were many different logistical and weird challenges that we had. But we came through it really well. And we have a great group of physicians who we have a COVID task force. We meet once a week and we all get together and figure out what we're doing. And when the surges come, we meet more frequently and we manage each other's issues and help each other and coach each other along. There's about 25 of us who joined this call, and it's been instrumental in shaping policy for treatment and running the hospital in general. So it's been an incredible journey. But, you know, I do want to say that a few things about COVID. So the first thing is, you know, it's now the 3rd leading cause of death in the United States after heart disease and cancer. So we're coming up on 1 million people dead, which is inconceivable that we've got to that point. We've lowered the life expectancy in this country by 2 years, which is the first time since the turn of the century that our life expectancy's gone down. Every American has lost an average of 9, knows people they've lost. And, you know, but only 3% of Americans have actually lost a family member, which means 97% have not, which is part of the problem of managing this whole thing. And I read this article from The Atlantic magazine, which I thought was really incredible. And I just want to quote a couple of things from it. So elderly people over the age of 75 are 140 times more likely to die from COVID than someone in their 20s, 140 times more. Unvaccinated people are 50 to 60 times more likely to die than vaccinated people. You know, those are pretty incredible numbers. We will likely stabilize out at somewhere between 50 to 500,000 deaths a year going forward. But, so basically, we'll stabilize out at a level that's going to be equivalent to smoking. And it's pretty remarkable when you think about that, because it's very analogous to smoking. You know, there's one quick intervention that can stop you from suffering lung cancer. And there's one quick intervention that can, given the numbers I just quoted, more or less save you from dying from COVID. But nevertheless, 50 years ago, half of Americans smoked, and it's now down to 1 in 7. So I guess that's what's going to happen with vaccination. Slowly, over decades, the unvaccinated population will come round, just like the smokers have, and more people will get vaccinated. But it's going to be a long, slow, and painful and tragic journey along the way. You know, the vaccine's really safe, and not only the parallels continue. You know, people who smoke and have secondhand smoke injure people around them, and people who don't get vaccinated are more likely to pass it on to others who are vulnerable. So the parallels between smoking and COVID are really strong, and we're going to be on a journey with COVID and vaccine, just like we have with smoking. And so, you know, at this point, we're headed towards probably another variant of the subvariant of Omicron, the BA2, which I'm sure you've all read about. It's spiking now in London, Hong Kong, and New York. It's probably a matter of time till it comes here. So we shall see what happens. But the treatments keep evolving. You know, we have the remdesivir and that monoclonal antibodies and antiviral agents, and they keep churning out. And you know, so there's a lot to be hopeful for and grateful for. And I think that you know, unfortunately, it is going to be a problem much more significant in the unvaccinated community. And the people who smoke and the people who are unvaccinated tend to be the same group of people as well. Lesser education, lower socioeconomic group. So there's a lot of tragedy associated with all of that. And you know, what we need going forward is better ventilation in public spaces. We really need universal health care. I wish we had the system that we had in Australia, which is a good quality universal health care for everybody. And then if you want to pay more to increase the tier of your care, you can. And it works really well there. You know, we just have to keep advancing treatments and push the vaccine and hope that people make the same journey they have with smoking that they have with the vaccine.
Thank you for that analogy. I have not heard that, smoking and COVID. So can you tell us how you prepare as Russ Kaino, MD, in the emergency room as you look ahead towards COVID? And then how are you preparing as Russ Kaino, husband, father, as you look ahead towards what we may be experiencing with COVID?
Yeah, so I think the first thing is, on all counts, is to make sure that you're vaccinated as much as is available and possible. So vaccine and booster, that's really important. I think that the levels of, there's this balance between societal disruption and managing COVID, with shutting things down and masking and requiring vaccine status checks at doorways to events and things. Unfortunately, the United States is unique in that it's, as a developed country, it has the worst record of any developed country for COVID deaths per capita. And all the other developed countries in the world have bounced back, and we have not. We are uniquely and particularly bad at how we've managed COVID as a society. And my concern is that Americans' tolerance for putting up with the things that we need to put up with to make it safe is pretty low. And that's why this problem is as serious as it is here. So I think we need to be more careful often than some of the mandates would dictate. So I think for the foreseeable future, if you're going to go to the market to buy food, you should wear a mask. I think that if you're going to indoor events, you should wear a mask, even if you're vaccinated, because I think we're going to lift all the mandates when there's going to be 1,000 people a day dying from COVID. That's the level at which the CDC and the White House have said, okay, at that point, we're going to lift all these mandates. And that's because half the population doesn't want them. Mm-hmm. But there's going to still be almost, half of the number of people that died on 9/11 dying every day when all those mandates are lifted. It's a little crazy, but still, it is what it is. So in terms of what we will do at the hospital, our tent is staying up. All of our precautions, we're going to be wearing masks. We're wearing masks indefinitely. We're taking all the same precautions with every patient that gets admitted gets COVID tested. Every surgical patient gets COVID tested. We have to adjust our approach in that regard. So that's on the work front, and on my home front, it's kind of similar. I don't feel comfortable going to a crowded restaurant and eating indoors. I think it's still too hazardous. And partly because the vaccine wears off. I had my last vaccine in August. I know that I'm essentially unvaccinated now because my antibody levels would be really low. They decay rapidly within 3 to 4 months. At 16 months, at 6 months, you've got 16% of the immunity you had a month after your booster. So, having had 3 vaccines is no silver bullet, and it's not going to necessarily prevent you from getting pretty sick. You may not die, may not be in hospital, but you might be sick for a month, and you may have long COVID for years with all kinds of problematic disorders that we're just struggling to understand and get our arms around medically now. So that we have no clue about long COVID and who's going to get it, whether you're vaccinated or not. So personally, I don't eat in, if I go to a restaurant, it's always outdoors. I'm not going to go to a movie theater. It's a risk I don't need to take. I feel comfortable at work. I wear an N95. And we don't get sick at work. And most of the nurses and doctors who have got sick, they've all said to me, I don't think I got sick at work. It was when I went to the market and I didn't wear a mask or something like that. So I'm not worried at work, and I'm pretty vigilant outside because I have a unique perspective and seeing what happens to people, and it's really heavy. So I'm going to continue to be careful indefinitely. And I think we're going to just have more variants come and go for some years yet. So that's my perspective there.
Thank you. And that dovetails into a question we have in our chat of, will we need additional boosters? So I'm hearing that, yes, get your booster when you can, and then as we foresee additional subvariants, that we will possibly need specific boosters for what happens in the future.
I think the important thing there, of course, there's no question we're going to need more boosters. However, the one really important thing I'll tell you is don't rush and get your booster. You need to time your booster for the next variant wave. So if you get, let's just say, like I mentioned to you, I got my last shot last August, and I debated going and getting a 4th shot for Omicron. But then I thought to myself, the chances are there's going to be more variants. The next one might be worse than Omicron. So I'm going to risk getting Omicron and not get boosted again. And I'm going to wait, because if the next one's more serious, I want to save my 4th shot for that. Not only that, we don't know about this. How many times, how many boosters can your immune system handle? And is there such a thing as immune fatigue? In other words, can you tire out your immune system such that future boosters will not be able to have the effect on your immune system that the first 3 or 4 or 5 have had? We just don't know. So I think you need to be very thoughtful about your boosters and time it. But if you see a wave coming and it's going to be a bad wave, I'd get a booster several weeks before that, so that your peak immunity occurs during the peak of the wave. So don't rush out and spend all your money before you need it, sort of thing. And also don't do indiscriminate boosters, because we don't know about immune fatigue. So yeah, that's my advice about vaccines and boosters.
Thank you. Well, staying in that medical advice vein, moving out of COVID, but you can also attach COVID precautions into this. What are some things that we can do to ensure that we're prioritizing health and keeping ourselves out of the ER unless we absolutely need it with something that is of high level?
That's a really great question, because something quite remarkable is happening now. We are seeing more heart attacks and strokes and serious illnesses than we have ever seen before, all of a sudden. And we think it's due to 2 things. Number one, it might be due to COVID. It might be that a lot of these people actually either for sure had COVID or had it asymptomatically and are now experiencing clotting disorders. And that's why so many of them are having strokes and heart attacks. It's staggering. We just can't believe it. We went from maybe seeing 1 or 2 strokes a day to like 6 or 7. It's like, what is going on? Same with heart attacks. So that's one part of it. And the other part of it is a lot of people deferred maintenance care for a couple of years. And I think that too has taken a toll. So people weren't getting their routine checkups and monitoring their cholesterol and blood pressure and things like that. So those 2 factors, I think, have potentially come together in a sort of unfortunate synergistic effect and produced a lot of illness. We don't know how much of it could be related to long COVID. So I think that going forward, given that we have vaccines and masking, and by the way, something that's really hard to understand and counterintuitive is just how ridiculously effective wearing a mask is. It's weird. It doesn't really make sense. Even as a doctor, I would say, gosh, I'm really surprised that wearing a mask can make that much difference, but it does. And so going to doctor's appointments and looking after yourself, but being diligent and wearing a mask when you do anything that you do, I would advise wearing a mask, because before we had vaccines, and we were working neck deep in COVID in the ER.
Mm-hmm.
Once we had N95s, none of us got sick. I mean, it was just like, it was impossible to explain. It's just like this stupid little paper mask is doing this, but it did. So the masks really, really work. So given that the vaccine effectiveness wanes, I would strongly advise wear a mask when you have to go and do an indoor thing, like go to the market and stuff like that. Therefore, what I'm segueing to is keeping going with all of your doctor's appointments and maintenance health care is really important. And, make sure you're vaccinated and wear a mask. And there shouldn't be any risk to going to any of these doctor's appointments for any of us between those two layers of protection. No significant risk compared to the risk of not maintaining your health and having that endoscopy or having that colonoscopy or having the blood pressure check and seeing the cardiologist or whatever it is you need to do.
And how do you share with those that come into your ER room, either the patient or those around the patient, and they are dealing with the fatigue of COVID, the fatigue of having that mask on their face? Like, you've had to give terrible news to people before. I'm sure you've figured out just the way to encompass this like nugget, kind of like you said, how ridiculously useful the mask has been at reducing COVID. So is there some phrase or what do you use to help sway people when they are feeling like, I've had enough of this, can we please just be done?
Yeah, it's not easy to persuade people. Those who've made their minds up not to wear masks or get vaccinated, it's very unfortunate the way all of this came about through a political kind of route. I even have doctor friends who were reluctant to get vaccinated, and I said, well, are you allowing your political beliefs, to override your understanding of science and the fact that you went to medical school? And they all ended up getting vaccinated, of course, but they didn't really want to, and I had to twist some arms. But that's how deep it runs. So I have found actually it's almost impossible to persuade people who've decided they're not going to do it. But I just try to share with them what I've shared with all of you, that the vaccines are incredibly safe. They're one of the safest things we've ever had in medicine. But still, I have people who say, but doc, isn't it going to change my DNA? And I'm like, no, it's not. And I explain it all to them, and I'm like, so are you going to do it? Nah, not going to do it. That's just how it's come down in this country and other countries too, to some extent. But it's remarkably pointed here, I think. Anyway, so we just try to explain the same things I explained to all of you about the effectiveness of the mask, how once we started wearing masks, we stopped getting sick, and we were treating in the room intubating COVID patients all day long at the beginning without being vaccinated. And it was, we hung our whole futures on those masks, and they worked. So, I try to explain it to people, but I think it's, like I said, it's going to be a many, many year journey of people learning to adapt to that. I see a question in the chat about children. Advice about kids wearing masks in school. I have a 5-year-old daughter, and she's not mandated to wear a mask in school. I have a 5-year-old daughter too. And firstly, the minute she turns 5 in a couple of weeks, I'm going to get her vaccinated. And given that this subvariant of Omicron is on its way, I think it's foolhardy to lift mask mandates at the moment. And my personal feeling is everyone should be wearing masks if they're indoors at school. I think obviously being outdoors is 20 times safer than being indoors. It's a profound difference. So indoor anything, I think, should be masked still. I don't think the county should be lifting their mandates. I think there's political pressure to do so, and it's extremely unfortunate. People will get sick and die as a result. So I think kids in school should be wearing masks for the foreseeable future in the classroom.
Okay. And to piggyback on that, there's also a question about asking your opinion on the vaccine for children under 5. If the FDA approves that, do you feel that that is safe, or what is your viewpoint on that?
Yeah, the problem with that is it's just not effective. They're not getting an antibody response. So that's the problem. I don't think any of us are worried about long-term effects of it. I think we're worried because it simply doesn't work. Kids under 5 don't mount enough of a immune response, and the first go around of Pfizer, the dose wasn't. They think now maybe the kids need to get a closer to an adult dose in order to, or at least the same dose as the 5 to 12-year-olds are getting to produce the effect. So, we have seen kids extremely sick from COVID, and children have been dying from COVID, including babies. So, I think the risks of COVID are greater than the risks of anything foreseeable from the vaccine. So as soon as there's a vaccine that works in under 5-year-olds, I would recommend doing it. I think it's the lesser of two evils. I would rather not get my kid vaccinated too, but I'm going to do it because I think it's the lesser of the two evils. And we don't know about long COVID in kids. And what will long COVID lead to? What problems in the future in their adult life? Could it cause cancer? Could it result in, sort of chronic fatigue syndrome or arthritis or some sort of heart problem or lung problem? We just don't know. So I think the risks from all of those things are greater than the risk of a vaccine and the fear, the innate fear we all have of having something injected. But I think we should be more afraid of the long-term and unknown effects of COVID than the vaccine. It's a tough choice, but to me, it's a clear choice.
And then going back to boosters, there's another question in the chat. If you got your Pfizer booster, should your next booster be Moderna? How do you feel about, switching or keeping a protocol of the same vendor?
Really good question. I mean, technically speaking, it looks like, 2 or 3 Pfizers and then a Moderna is the best way to go. But the Moderna has a higher incidence of pericarditis, or this heart inflammation. So it's a bit of a difficult choice too, in a way. But the incidence is low, and it usually happens in young men. So, I would say probably for young men, it's maybe better to stick to Pfizer, but for most others, it's probably a smart idea to do a Moderna.
And then Lois asked a question about, for women, are there any unusual signs of a heart attack that we should be aware of? And Ms. Green, you can indicate if that is, relating to COVID and boosters or just general health.
Well, I can tell you that in general health, women experience heart attacks often very, very differently from men. And it's something that we're very attuned to. Much more often than not, women report very ephemeral and vague symptoms like difficulty sleeping, fatigue, shortness of breath, but not chest pain like men do. So women's symptoms tend to be a lot more vague and hard to pin down than men. So for us, we're very careful. When we assess somebody for a heart problem, our biggest job is to put it in context. so that we interpret the symptoms within context. So the context is risk factors for heart disease. So if someone comes in with a worrisome symptom, but let's say you have two people with the exact same symptom, and one of them has all the risk factors for heart disease, high blood pressure, high cholesterol, family history, then the diabetic, and they've had a previous heart problem, and they smoke. The way we interpret that maybe vague, fleeting shortness of breath or discomfort or whatever is completely different than in someone who doesn't suffer from all of those background contextual risk factors. So that's how emergency physicians divine who's likely to have a heart problem and who's not. And that is really important. And it's part of our algorithm, our decision algorithm in figuring out, together with EKGs and getting blood tests and other tests like that, and talking to the cardiologist about it, possibly, or doing a stress test. All of these things, you put it all together and you come up with a risk profile. But we have to be a lot more careful in women because it's a lot harder to nail it properly. Great question.
Yeah. I would love for you to share your restaurant analogy about the ER with our ladies, and also maybe your piece of advice for anyone if we find ourselves in need of going to the ER. Is there a top 3 list of some things that we need to check off as we're getting ready to visit? Or as the head of the ER, what would you like patients to know coming in or preparing to come in?
Okay, so the restaurant analogy is something we started quite a few years back. And here it goes. So, when you go into a really nice restaurant and it's completely full, there are no tables free. So they sit you at the bar and say, hey, why don't order a drink? You can even order an hors d'oeuvre if you want while you're waiting. And by the way, here's the menu, so you can pick what you want from the menu. So that way, by the time you sit at your table in 20 or 30 minutes from now, when that table becomes available, your food will be ready and we'll seat you at the table. And at the same time, your food will come. So you won't have lost any time by virtue of the fact we can't seat you right now. Sit with your friends at the bar, have a drink, have an hors d'oeuvre, and order your dinner. So with that in mind, that is what we started to do at St. John's in the ED, the emergency department. We, when a person checks into the waiting room, we have one of our advanced practice providers, either a PA or a nurse practitioner, come out to the waiting room, take a very quick history in a private room, just off the waiting room, get a quick sense of what's going on. They can order lab tests, order the X-ray, order IV fluids, order medications, and get everything rolling. So by the time I get to see you, maybe we've even ordered a CAT scan or a lung scan. By the time I see you, and by the way, our door to doctor time at St. John's is about 15 to 17 minutes. So we get to you quickly. On average, that's an average time, 15 to 17 minutes, door to doctor time. So we get to you quickly and we get all these tests rolling. So let's say my nurse practitioner or physician assistant got all that, ordered the CAT scan, lab test, pain medication, maybe even antibiotics, if it's obvious what the problem is. By the time I get to see you and you get brought back to a room when it becomes available, all of that stuff is back already. And I can make a decision to admit you or discharge you right away, or call the specialist I need and get you admitted. So it works exactly the same as that restaurant analogy. And we call it RME, Rapid Medical Evaluation. And basically, it's what we, it is essentially the same as that restaurant process. And then what should you do if you think you need to go to the ER? Well, before that, if you've got a regular doctor, you should call that. And often the doctor will call us and say, hey, so-and-so's on their way in. can you let me know what happens? Or, can you take care of them and admit them to so-and-so? So it's a really good idea to call your doctor before it gets to a 911 sort of situation. But either way, whether it's a 911 situation or it's you're calling your doctor and deciding to drive in, the most important things is to bring a list or bring the actual bottles of all your medications so we know exactly what you're taking. We really, really need that. We try to do what's called medication reconciliation with every patient we see. So we've got to go over all the medicines and understand what you're taking and why you're taking it and what you're allergic to. So we really need that. If you've got a complicated medical history, it would be great to have a list of all the things you've had. So, when you're in the heat of the moment, it's hard to remember everything. So having stuff written down on a list of what you've got is great. If you've been our patient before, most likely it'll all be there in our Epic electronic health record, which is wonderful. And we can pull it up on the fly. I can pull it up on my phone from anywhere and see what's going on. So it's really cool and powerful. And it's definitely the future for healthcare. And then I think obviously, coming with a family member who's robust enough to withstand the waiting room ordeal, because in this day and age, for the most part, with all of this COVID, people are having to wait outside in their cars or outside the ER, and it's tough, it's difficult. And right now, family members are able to come in, but in a few weeks from now or in a month from now, when we're in our next surge, we won't be able to, through an LA County ordinance, we won't be allowing anybody into the ER. So come with a fully charged phone that you can FaceTime with your family member who's out in the car. And we can have a three-way conversation when the doctor comes into the room, and you can FaceTime with the family member, with the patient next to you. And so your medications, your past history, and a fully charged phone and a family member who's strong and tough enough to be your advocate and be out in the cold or the waiting room or the car or whatever COVID's going to mandate. So that's my advice.
Terrific. Such great wisdom. Thank you for that. And thank you for sharing your wisdom with us. Ladies, I'm going to open it up. If any of you have questions, if you'd like to unmute yourself and ask that of Dr. Kaino. I know we never want to visit him at work, but I would love for you to be able to speak with him now and ask any questions that you might have while we're waiting for those. I wonder if you would share a bit about how St. John's has helped care for those that are uninsured or mentally ill, or those that are homeless. I know we're not unique in our situation of our population like you serve in Santa Monica, but maybe a bit about how you maneuver in caring for all of those folks.
Yeah, well, in some ways we are unique because being close to the beach, and being in Southern California. So because of the weather and the beach, we actually do see a lot of homeless patients for our size hospital, a lot. And we have some pretty unique programs. We have a homeless navigator who works to find permanent housing for our homeless patients. And we've had amazing success with that. We've had, just to tell you a story, we had this one guy who always was around the emergency department, who would visit us every single day. And, after hundreds and hundreds of visits, it was a problem for him and for us. With him, we were successful in finding out where his family was. And it turned out they were in Tennessee or Oklahoma. And we were able to repatriate him back to his family. And he sent us a photo of him at his Thanksgiving table with his family. And it was so incredible for us to see that after treating him for years, once we got this homeless navigator program up and running. So we find permanent housing either with their original family or even locally. We will help them get access to shelters. We check their vaccination status. We make sure they have clothing. We have a homeless closet. We give people shoes and warm clothes and medications and food. And we try to give them everything we possibly can. In fact, it's in my opinion, it's incredible that we as an acute care hospital trying to look after critically ill heart attacks and strokes are doing this, because it's a case of mission creep. Really, there should be agencies set up in the community separate from us doing this. But somehow it's fallen to us to do it, so we do it. And I think, honestly, I think as a hospital, we go above and beyond. We partner with the Venice Family Clinic. We do a lot of community outreach. We support all kinds of, and to a very large degree, millions of dollars a year in money donated to the community to help the Santa Monica and the West Side community with homelessness. And all of that dovetails and crosses over into mental illness and drug abuse. Mental illness is a big, big problem because the resources for it are shamefully inadequate in LA County, especially nationwide, but more here than anywhere in the nation. We have just an absolutely shameful lack of mental health resources, and it's very difficult to care effectively for these people, especially if you have an adolescent or a kid who's suicidal. Finding a place to place them in a safe environment that's not even more adverse for them is so challenging. And we have patients that sometimes wait for days and stuck in the ER in a room for days before they get placed to an appropriate facility. And even those appropriate facilities can be pretty bad. You can take a semi-normal kid and they're being hospitalized in a very challenging environment. So that's probably our most unrewarding challenge that we have to deal with, is care for the mentally ill. And the homeless population is a big challenge because of the size of it, and Santa Monica is very challenging. But there are a lot of really great programs, and there's more and more coming online every day. And the shelters and Venice Family Clinic are really great partners, and there's a lot going on in the community and a lot of attention and energy and focus, which is pretty gratifying. So, we can't square away everybody perfectly, and sometimes we have to discharge people with the shoes and warm clothes, the medicine, some food and vaccinations, and we have to send them back out. And a lot of people don't want to be put in a shelter, or they don't want to be put in permanent housing. They're more than happy to be out there in one way or another. Maybe that's not the right way to say it, more than happy, but that's what they want. They refuse to go to a shelter, or they refuse to let us find permanent housing for them. They just want to go back out onto the street, which is heartbreaking, but we've got to do what we've got to do.
Well, thank you for your service to all of the members of our community. Laura Galloway has a question, so I'm going to ask her to unmute and go ahead and ask that.
Hi, thank you so much for presenting today. It's been really interesting and taking a lot away. So my family had a medical emergency happen at home this past December. Luckily we were able to call 911. My mom and I both knew CPR, so we were able to start that with my dad really quickly. But it made me think, as a mother and my mom as a grandmother and children in the home, like, what things would you suggest that we need in the home to help prepare for any sort of medical emergencies before we had to call 911, or before the ambulance could come? I get ads all the time about these like sort of de-choking instruments. I don't know if they work or not, but what do we need to do to help sort of prepare? I have Band-Aids, but nothing much more like robust the NAT at home. So
Yeah, great question. So for sure, CPR and the Heimlich maneuver are the two big things that, everybody needs to know, and it's life-saving and really critical that you can do those. And I've done both of them many times on many patients in one form or another, and it's pretty incredible. We had a patient the other day who had a cardiac arrest in the ER. And just to give you an idea, when we were pumping on his chest, he was awake and talking to us. The minute we stopped pumping to assess his rhythm on the monitor, he was unconscious. We'd pump again, he'd wake up and talk to us. We'd stop pumping, he would out. And it just goes to show you how incredibly effective that pathetically simple maneuver is. His brain was being perfused perfectly with the pumps, and then not at all when we stopped pumping. And that was, to me, was the most graphic display of how pushing on someone's chest pumps blood around their body and perfuses their brain. So that's number one. Number two is the Heimlich for sure. Number three, I would say things like, if your family member has an allergy, having an EpiPen, those kinds of things. If there's a need for that, if there's a kid with a peanut allergy or a bee sting allergy, having an EpiPen can be life-saving as well. But those are really the main things, I think. There's not really a whole lot of other things that are so life-threatening. I think recognizing a stroke, for example, slurred speech, treating a stroke rapidly, as quickly as a heart attack, is equally important. They say time is muscle with a heart attack, but time is brain with a stroke, and every minute counts. So if a person suddenly has a bit of slurred speech or numbness in one arm or drooping of one side of their face, get to the ER as soon as you can. It's a 911 call, because we will be all over that instantly. We have a code situation for three things: a code for a heart attack, a code for stroke, and a code for sepsis, which means those three things, it's all hands on deck, and we jump on those patients, all of us, and do everything to that patient immediately. A stroke patient comes in, we get them to CAT scan within minutes, and we either get them, if it's a large vessel, we get them up to the cath lab, and we can go in with a little wire, a catheter, and unblock the vessel in the brain. We can go in through the wrist or the groin, and the same with the heart. And people have incredible long-term outcomes from us doing that. And I go back to normal. Had we not been able to do that quickly, they would have been paralyzed and unable to speak for the rest of their life. So recognizing a stroke, I would say, is very important, and that can be very subtle. So reading up on that and knowing how to identify that. Then the rest is really common sense, dehydration and being careful of just, if someone's got vomiting and diarrhea and not keeping any fluids down, they can become dehydrated rapidly and damage the kidneys easily. So you've got to be careful with things like that. But if someone's got diarrhea, but they're able to keep a lot of fluids down, that might be okay, but you've got to be careful what sort of fluids, because your electrolytes can become very disordered by just drinking normal water. So drinking Gatorade as a replacement is safer. So the rest of it tends to be common sense, but I would say those four things are the big ones to be on top of.
Fantastic, thank you. Well, we are nearing the end of our time together today. So again, Dr. Kaino, thank you so much for sharing your precious time with us and your expertise and knowledge. And thank you for just couching it in such ease and comfortability. So we really appreciate you and your work at St. John's and all of your colleagues. So thank you so very much.
Thanks, Vanessa. Thanks, everybody. It's really been my pleasure and a lot of fun for me, and great to meet with you all, and be well. And we're here if you need us at St. John's.
Fantastic.
Yeah.
I'd also like to thank from the St. John's team, Mary and Cookie and Taylor for helping to bring this together for you all, and to our benefactor, Kathy Don Hockle. Thank you so much. We will meet again on Zoom next month in honor of recognition of Autism Month. We are going to have one of our faculty members come and share more insight about that developmental disorder. And that will be our final session for the beginning of the year. So we will return in September, and there's talk of being in person possibly. So do stay tuned. So thank you, everyone. Have a beautiful day. Stay healthy, get your checkups, and we'll see you next time. Thank you so much. Bye-bye.